Welcome to another episode of Brain Buzz, where we delve into the fascinating world of neurosciences and brain health. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
All right, Jason, this is another episode. Today we're going to talk about idiopathic intracranial hypertension.
That's a mouthful.
A mouthful for sure. Another term for this is pseudo. So this is a headache syndrome. So a headache syndrome that we actually can fix with surgery.
And, that's fantastic. And a lot, like you said in our last podcast, a lot of what we deal with starts with a headache, unfortunately.
Right. And so idiopathic intracranial hypertension is a headache syndrome where folks experience tremendous headaches, pressure headaches, and then in addition to the headache, they can often have visual problems. And I want to tell you a little bit about kind of what constitutes idiopathic intracranial hypertension. For short, we call it IIH, right? And so what that is increased pressure inside the brain. And normally all of us have fluid inside the brain, fluid spaces that are filled with fluid, what we call cerebrospinal fluid, CSF. And when the pressure in that fluid is high, the brain gets compressed, but also the optic nerve gets compressed because that fluid is transmitted into the optic sheath, and there's pressure inside that nerve, and the nerve can be affected, and people can lose vision, and so that's kind of the whole syndrome, and it's a tough syndrome to treat. It's a tough disease, and I would say in the past the majority of the treatment had to do with regulating that pressure in the fluid in the CSF, either by taking medications like Diamox, which is a diuretic, a water pill, so that you can get that extra fluid out of your body. That has its limitations, of course, and some side effects. And other types of treatments were more invasive and had to do with surgery, putting a shunt or a thin cyclastic tubing inside the brain, inside the fluid spaces, bringing the fluid underneath the skin all the way into the belly where it gets reabsorbed and eventually removed from the body. And so you had these two very different approaches that were not always very effective. And so now we've transitioned to the point where us at the Stroke and Brain Aneurysm Center of Long Island can treat this disease with a needle stick in the groin. Go ahead, sorry.
Oh, no, we've come a long way.
We have come a long way. And the reason we're able to do that is because we understand the disease a lot better, right? So we understand that the way the fluid, the CSF, leaves the brain is through our veins. The big veins in the brain, what we call venous sinuses, that then drain into the heart eventually. And their other function is to take blood that's brought by the arteries into the brain, take it back into the heart. But also, they remove the excess fluid because we constantly produce CSF. They remove part of that fluid. Now, if those veins have a blockage, or what we call technically a stenosis, then the pressure gets backed up, the fluid doesn't drain adequately, more pressure, and you have IIH. And so if you could fix that blockage, which that's what we do, right? We're, like I've said before, we're glorified plumbers. We fix blockages in blood vessels. So what we do is we would place a stent in that area, and that would allow the fluid to more easily come out of the body. The pressure would go down, vision would be preserved, and the symptoms of the headache would generally go away. So that's kind of how we've transformed the field, and I think you and I are seeing a lot more of these cases now.
Yeah, no, we always tend to be adding something to our repertoire at the Stroke and Brain Aneurysm Center, and this year we kind of are leaning more towards this.
Right.
What causes this?
So, I think, like I said, in the past, we didn't know exactly what caused it, and hence we called it idiopathic intracranial hypertension. Idiopathic in medicine is code for we have no idea. And that's exactly what was going on. We didn't really know. And now we do. We understand that it's flow dynamics, and it's the plumbing of the brain is deficient in a way, and that pressure builds up. And one of the biggest causes of that is the venous problem. The vein is not adequately allowing the blood to flow. And when it comes to understanding if there is a problem with the vein, obviously anatomically when we do an angiogram, which, we've talked about before, which is the study we do when we go through the groin with catheters and wires and take pictures of the blood vessels of the brain. But when we see that there is a blockage anatomically, that area looks narrow, that's one visual cue that we might have a fixable problem that causes the IIH. Now, to be 100% certain before we put a stent in, what we do is we measure the pressure across that blocked area. So naturally, if that blockage is significant, you have a pressure gradient. The blood gets backed up. So there's higher pressure before the area of the stenosis, right? And so if that pressure differential, there's different schools of thought, but what we do is if it's over 8 millimeters of mercury, then we generally think that a stent would be helpful to decrease that gradient and allow the symptoms to go away.
Now, you had mentioned an angiogram as a way of diagnosing it. Are there other imaging means?
Yeah, so the angiogram doesn't really diagnose IIH. What the angiogram does, it helps us understand if there's a fixable cause endovascularly on the venous side. The way you diagnose the disease is actually very different, and it's not a single test that will give you that information. It's a combination of things. First of all, you have to have the stereotypical headaches, the vision problems, the swelling deep inside the eye, what we call papilledema, well, where the optic nerve is swollen, and then you need to have high pressure in the fluid of the brain. Now, the fluid that's inside the brain is also inside our spinal canal, and so the same pressure that's up there is down below, and so we can with a lumbar puncture or a spinal tap, we can measure that pressure. We don't have to go straight into the brain to measure the pressure. And we measure the pressure. If the pressure is elevated and you have all the other things kind of falling into place, then most likely what you're dealing with is IIH. Now, there's some diagnostic criteria, obviously, of what you can and cannot have, and obviously fairly technical, but that's the baseline of how you diagnose this disease. And IIH tends to be more common in ladies. It tends to also be in more overweight ladies. And so often an initial recommendation that folks would give was weight loss. They would say, lose weight and symptoms would improve, which is not necessarily wrong, but it's fairly challenging sometimes. So, the going the weight loss route might not always be effective or might not be as quick as you want it. So, say somebody's losing vision. You cannot be waiting for a year or two for somebody to lose weight. By that time, vision will be completely lost. So now this minimally invasive treatment that has been developed really allows you to get ahead of the problem without having to wait, of course.
Yeah, because I would think it would be a significant amount of weight loss, not 5 or 10 pounds.
It would be a significant amount, and keep in mind, sometimes it wouldn't really make that substantial a difference at the end of the day. So, of course, we have to understand the disease better, and it's a multifactorial treatment, right? And the fact that we've kind of shied away a little bit from shunting in these patients is important. Like I said, that piece of tubing that would go from the brain all the way into the belly, that has so many problems, frequently malfunctions. It can get infected very frequently. We don't want to go that route if we can avoid it. And I'm very happy that now we're able to avoid that type of treatment option. And you and I know we've had a lot of very happy patients with this type of treatment. And another thing these folks get that I failed to mention before, if the blockage or the stenosis is significant, they might get pulsations in their ear. So what we call pulsatile tinnitus, which of course can be the result of other things, other problems in the artery side, like an aneurysm or a fistula, arteriovenous malformation. But sometimes it's the result of a venous stenosis or a venous blockage and IIH in the same setting. And if that's the case, you can fix that problem at the same time that you're fixing the pressure problem, right? So frequently, I see these patients in the office, they say my headache is gone, but, I cannot hear my heartbeat anymore, which is amazing. And that's pretty spectacular.
Yeah, so pulsatile tinnitus, what exactly is that?
And
what did a patient, what would they experience?
Yeah, so pulse synchronous tinnitus is when you can hear ringing in your ear. That's the tinnitus aspect, but you hear it at the same time as your heartbeat. So it's synchronous or at the same time as your heartbeat. And it's very, very stereotypical, and it's rarely without a cause. When you develop pulse synchronous tinnitus, it's generally some sort of vascular abnormality in the brain. It can be something very benign or something more significant that is going on, and sometimes we can fix it and treat it. Oftentimes, if, for example, somebody doesn't have IIH, but they have venous stenosis causing that problem, and it doesn't interfere with their life, they might not want to go through the process of getting a stent
Sounds
in the
annoying
brain.
though.
It is. So for some people, we've had, very well, we've had patients that have gone into a full psychotic break because of the intensity of pulse synchronous tinnitus.
Yeah, no, I mean, it's kind of life altering for them.
Right, of course.
Um, we talked about the neurological eye exam.
Right.
So, at what point should you be worried if you're having vision issues that it could be this?
So, of course, anytime you have vision issues, see your eye doctor, see your ophthalmologist, and they'll be able to determine if the vision problem is from the lens or the other components of the eye, or if it's coming from the brain or increased pressure inside the brain. But if you've been diagnosed with IIH and you're on Diamox, which is the pill, the water pill that is treating that increased pressure, and you're having side effects from the water pill, and you're not very happy with it, and headaches are persistent, and you're starting having visual problems. Now that's a situation where you should be seeing your eye doctor right away, and probably talking to a neurosurgeon or a neurointerventionalist for that problem.
And I was kind of smiling when you said water pill, only because that brought me back to my grandmother. That's what she used to be on for different reasons,
Right,
but she used to call it her water pill when I was
right.
younger, and that's all I knew it as.
It
So
brought you back.
yeah, it
But
did.
yeah, no, I mean these are very old treatments, and Diamox is a really, really old medication, and that comes to show you how kind of all this research and understanding of this disease is fairly recent, because we have such old treatments
Mhm.
that we've used for it. Uh, but certainly now we have the ability to very, very effectively treat it, and diagnose it and study it. And it's a good example of multidisciplinary collaboration, right? It's not just a neurointerventionalist, not just a neurosurgeon, a neurologist, an ophthalmologist. So all these different principles are getting together for one patient, and not a single principle can effectively treat this disease. That's pretty amazing. Most other diseases that we have in our world, we can take care of by ourselves. Of course, there's medical components or integrated neurologist, but this is a really a testament to multidisciplinary collaboration. And as building a center for IIH, you need a very good neuro ophthalmology, or an eye doctor that deals with the brain partner. You need a good neurologist, and of course, a good neurosurgeon, neurointerventionalist.
And there's not a lot of neuro ophthalmologists around.
Not a lot of those folks around. A very esoteric field. Certainly on Long Island, where we practice, there's few and far in between, but they're all excellent, and we've had a great relationship with all of them. But you're right; it's a very, very tough field to find a specialist in.
So for a patient who is going to get the venous stent as a
Right,
means to treat this, um, what are the risk, and
right.
if it doesn't work, is there any downside for those who's done?
Right. So the risks are very small. Contrary to the arterial side, when we're treating a brain aneurysm or an arteriovenous malformation, the risks are a lot higher on the arterial side. Of course, you can cause stroke, you can cause significant deficit and disability, or even death if there's a complication. But on the venous side, things are a lot simpler in terms of the risks. Of course, there can be clotting in the veins or issues of that nature, but generally speaking, any complication is not as devastating. The biggest issue that folks encounter after they receive a venous stent is that they develop a post-stenting headache from stretching that vein, and that headache goes away typically in a few hours, but at most it would last about a week. And that's the most common thing that folks complain about. If it doesn't work, I would say it works in the majority of the cases if you select the patients appropriately, right? If you have to be sure that they have IIH, that there's a gradient or a pressure differential across that blocked area, very similarly to having a river that narrows down and you have the rapids and things are flowing fast. You got to be able to confirm that that's what's going on. And if you've confirmed all that, chance of fixing their problem is extremely high. If you didn't fix their problem, then there's probably some other etiology or something else going on, and it might be a problem with identifying that issue. And of course, if it's still idiopathic intracranial hypertension that's resistant to treatment with a stent, of course, shunting would always be an option. Decreasing the amount of fluid in the brain by just diverting it, bypassing the normal outflow and putting it into the belly.
That's definitely more invasive compared
definitely
to
more invasive, a lot more things to think about, and more finicky in terms of its propensity to get infected or malfunction.
With either treatment, either being a shunt being the bigger of the treatments, so to speak,
Right.
and the stent, how's follow-up care work?
So the way you follow up on these issues is, of course, you have to follow up with your neurosurgeon, your neurointerventionalist. You have to identify for a certain period of time, you need to be on blood thinners if you, for example, are getting a stent. And those are in the form of aspirin and Plavix typically, or another antiplatelet medication, depending on surgeon preference or other reasons. And you stay on that for a certain period of time, and then probably you'd stay on a baby aspirin indefinitely. After that, of course, you'll see your neurointerventionalist. They will do some imaging studies to make sure that the stent is patent. That can be in the form of an MRV, CTV, or an angiogram, depending on a few factors. And then you'll follow up with them. If your symptoms are resolving, you're on a baby aspirin, you don't necessarily need more follow-up. With a shunt, same thing. We perform head CTs to see and make sure that the fluid spaces are appropriately sized, to make sure that the shunt is in the right spot. And we follow patients for actually a lot longer than if we were to put a stent in and it works, right? Because the shunt can always malfunction. So we have to follow these folks for a very long time. There's no such, I do not foresee a stent for this particular indication malfunctioning or needing more interventions.
And I know from just my own personal experience that patients who have received shunts, then there's issues with MRIs.
Depending on the type of shunt you receive, although there's a lot of shunts right now, even programmable, or where the setting is variable, where you can regulate them and they're MRI safe. If you have a shunt that can be programmed, a lot of times those are not MRI safe, or they are safe rather, but their setting can change.
Yeah.
And so you have to
it's a lot more high
tune them in. A lot more high maintenance. Of course, everything we do on the endovascular side in terms of stents or other devices is MRI compatible, and there's no issues with it. And so you're right. There's once it's in, it's done. If it's working, there's not much else to worry about. Even if you didn't tell anybody that you had it, it's not going to affect the magnet.
Yeah, I mean, it sounds like if I needed this, I would want to stent.
Right. All of us, the least invasive issue, the least invasive treatment would be the appropriate one. But patient selection is key. I cannot overstate that. There's a lot of folks with headaches out there. The most common complaint we get in the office is what? Headache. So, if we put a venous stent on everybody, we're going to have a lot of people with a venous stent and a headache. So we're not really going to change the natural history of this disease. So we need to really select these patients very, very, very carefully. If you select those patients carefully, you'll have good outcomes, you'll have happy patients. But it's very important. Patient selection, I cannot overstate how significant it is to get the facts right when it comes to this disease.
That's very important to know. I don't have any more questions. This is kind of a straightforward.
Very good.
Out of the patients that we've treated, I think most have been female. I don't remember.
Yeah, no, we had males. Your memory deceives you. We've had males with chronic history of IIH, but a lot. Because we see so many women with it, we tend to forget the guys. But there's definitely guys that have it. It's uncommon. But in any event, if you're having headaches, if you're experiencing symptoms, of course, work with your primary care doctor, work with your neurologist, and if they come up with this diagnosis, then look into your options. Medical management will be always the first treatment option, but if you're resistant to that, develop other issues, have vision problems, then you will likely be redirected to some sort of intervention. Don't be afraid of these interventions in 2023. They are very safe and effective, and we're very proud that we're able to offer them, of course, at the Stroke and Brain Aneurysm Center of Long Island. And of course, if you have any questions, if you want to reach out to us, you can always find us on our website, which is www.strokecarelongisland.com. Of course, never forget to subscribe on our YouTube channel, which is at Stroke and Brain Aneurysm Center. Thank you again, and we'll see you in another episode of Brain Buzz. Thank you, Jason.
Thank you.